welcome to our deep dive, into the world of glaucoma.
Yeah.
You've given us some fascinating source material excerpts from what looks like a medical textbook, all focusing on glaucoma. And we're going to take you on a journey through some of the key takeaways from understanding what glaucoma is to the latest treatments, and hopefully leave you with some thought-provoking insights.
Yeah, it's like we're giving you a crash course in glaucoma without the medical school tuition.
Exactly.
We'll break down the science, the intriguing details, and what makes this condition so important to understand.
Buckle up. You'll never look at an eye the same way again.
Right.
So let's start with the basics. What exactly is glaucoma, and why should we care?
Well, glaucoma is a sneaky condition that damages the optic nerve, the cable connecting your eye to your brain. And what makes it so dangerous is that the damage often happens slowly and silently, without any noticeable symptoms in the early stages.
Oh, wow.
By the time people realize something's wrong, the vision loss can be irreversible.
That's scary. The source material mentions this fluid called aqueous humor and something about pressure. How does that tie into glaucoma?
Well, aqueous humor is a clear fluid that circulates inside your eye, nourishing it and keeping its shape.
Okay.
Imagine a basketball. The air inside is like the aqueous humor, and the pressure it exerts on the ball is like the intraocular pressure, or IOP, in your eye. In glaucoma, the pressure gets too high, and it starts to squeeze the delicate optic nerve fibers, damaging them over time.
So it's like overinflating the basketball. Eventually, the stress could cause a weak spot to burst.
That's a great analogy, and here's where it gets tricky. What's considered normal? IOP actually varies from person to person.
Oh, really?
The textbook says the typical range is 11 to 21 millimeters of mercury. But some people can have higher pressures without any damage, while others develop glaucoma even with pressures below that range.
That's a bit unsettling. So it's not just about a single pressure reading, though.
Exactly.
Yeah.
IOP naturally fluctuates throughout the day, often higher in the morning and lower in the evening. But in glaucomatous eyes, these swings tend to be even wilder. So a single snapshot might not tell the whole story.
So we've got this pressure situation that can damage the optic nerve, but I understand there are different types of glaucoma, right?
Right.
Is it all just high pressure?
That's a key point. It's helpful to think of glaucoma as broadly falling into two categories: open angle and angle closure.
Okay.
Imagine the angle as the drainage system in your eye where the aqueous humor flows out.
Okay, so open angle means the drain is open, but something's still causing the pressure to build up.
Exactly. In open angle glaucoma, the drainage system isn't completely blocked, but it's not working as efficiently as it should. Think of it like a slow leak in a faucet. The water's still dripping out, but it's not draining fast enough.
Right.
Primary open-angle glaucoma, or POAG, is the most common type and often has no clear single cause.
An angle closure glaucoma sounds more dramatic?
It can be an angle closure glaucoma. The drainage angle is physically blocked, like someone slammed the faucet shut.
Yeah.
This causes a rapid and often painful spike in pressure, and it can damage the optic nerve quickly.
Wow.
It's an emergency situation.
So how common are these different types of glaucoma? The source material throws out some numbers, but I'm not sure what to make of them.
Well, the numbers are important because they highlight how common glaucoma really is. The textbook says about 2–3% of people over 40 have glaucoma, and up to half might not even know it.
Wow.
And to make it even more concerning, primary open-angle glaucoma is especially prevalent in certain ethnicities, like people of African descent.
So it's not just something older folks need to worry about. How do we even know if someone has glaucoma? You can't just look in the mirror and see it, can you?
You can't. Unfortunately, that's why regular eye exams are so crucial, especially as we get older.
Right.
One of the key ways we diagnose glaucoma is by measuring that IOP we talked about. And the gold standard for that is a technique called Goldmann applanation tonometry, or GATE for short.
Okay, break that down for me. What actually happens during a GAT measurement?
It's actually quite clever. They use a special prism to gently flatten a tiny area of your cornea, the clear front part of your eye. By measuring the force needed to flatten it, we can calculate the pressure inside. And here's the cool part. They figured out a way to cancel out the effects of things like corneal thickness and the tear film, which could skew the results.
Oh, wow.
Theoretically.
Oh, but as with any measurement, I'm guessing there's room for error. What could throw off the reading?
You're right. There are several things that can affect gate readings. Corneal thickness is a big one. Thinner corneas can lead to falsely low readings, while thicker corneas can give falsely high readings. And surprisingly, even something like a tight collar can throw off the results.
Wait, a tight collar? How's that even possible?
It sounds strange, but it's true. A tight collar can actually increase the pressure in your veins, which can in turn affect the pressure in your eye. It's a reminder that even factors seemingly unrelated to the eye itself can influence those pressure readings.
That's definitely a counterintuitive insight. The source material mentions other tonometry methods, too. Why so many ways to measure eye pressure?
It's like having different tools for different jobs.
Okay.
The textbook describes methods like pneumotonometry, which uses a puff of air instead of contact, and the portable tonopen, which is handy in situations where you can't use the standard equipment. Each technique has its pros and cons depending on the situation.
Okay, so we've covered measuring IOP, but the source material also talks about this gonioscopy thing.
Right.
What is that, and why is it important in glaucoma?
Gonioscopy. This is where we get to peek into the anterior chamber angle of your eye, that drainage system we talked about earlier.
Okay.
It's crucial because it allows us to actually see if the angle is open or closed, which helps us determine the type of glaucoma and guide treatment.
So how do they actually see the angle? Is it like a miniature camera they stick in your eye?
Not quite a camera, but just as ingenious. It involves some clever physics and a special contact lens called a goniolens.
Okay.
The angle is normally hidden behind the cornea, but the goniolens bends the light in a way that allows us to see it.
So it's kind of like a periscope letting you see something that's normally hidden?
Exactly. And there's a surprising variety of goniolenses. Some with one mirror, others with 2, 3, or even 4.
Wow.
Each type provides a slightly different view, and the technician chooses the best one based on your eye's anatomy. The technique itself is a bit like getting fitted for a contact lens, but with a more dramatic purpose.
So they can see if the angle is open or closed, which helps determine the type of glaucoma. But what else are they looking for during gonioscopy?
They're assessing the overall health of the drainage system, looking for any signs of blockage damage or abnormalities.
Okay.
They could see structures like the trabecular meshwork, Schlemm's canal, and even tiny blood vessels. It's like getting a detailed map of the eye's plumbing.
Fascinating. So we've got IOP, and the angle, the source material then goes on to talk about the optic nerve head. Why is that so important in glaucoma?
The optic nerve head is like Grand Central Station for visual information.
Okay.
It's where all those nerve fibers from your retina bundle together to form the optic nerve carrying signals to your brain. In glaucoma, this is often where we see the first signs of damage from that increased pressure.
Okay, what does this damage look like? How do they assess the optic nerve?
Think of it like erosion. The nerve fibers start to die off, and the cup, the central pale area of the optic nerve head, starts to enlarge.
Okay.
We use the cup-to-disc ratio, or the CD ratio, to assess the severity of the damage. A larger cup, relative to the disc size, can be a red flag for glaucoma.
So it's not just the size of the cup that matters, but also the size of the disc itself?
Exactly. Big discs can have big cups and still be perfectly normal. It's all about the ratio. And they have a pretty cool technique for measuring this. They use a narrow slit beam of light from a special microscope to carefully illuminate and measure the edges of the optic nerve head.
And the source material mentions this ISNT rule. ISNT. Is that some kind of secret code for eye doctors?
Not a secret code, but a handy mnemonic.
Okay.
It stands for inferior, superior nasal temporal, and it describes the typical thickness of the neuroretinal rim, the healthy tissue surrounding the cup. In a healthy eye, the rim follows this thickness pattern. Inferior is thickest, followed by superior, then nasal, and finally temporal is the thinnest. If this pattern is off, it could be a warning sign for glaucoma.
So it's like a built-in early warning system in the anatomy of the eye. But let's be honest, anatomy mnemonics can be tough to remember. Got any tips?
I always remember it as isn't T. Time to check your eyes. A
No.
little play on words never hurts.
I like it. I'll never forget that now. But besides this ISNT rule, are there other subtle signs they look for in the optic nerve?
Absolutely. They'll assess the color and sharpness of the rim, looking for any pallor or blurring, as well as any abnormal blood vessels or other unusual features. It's like being a detective, searching for clues to piece together the story of what's happening in the eye.
And speaking of detective work, the source material dives into all sorts of imaging techniques used in glaucoma. What's the big picture here? Why is imaging so important?
Imaging has revolutionized how we diagnose and monitor glaucoma. It's like having X-ray vision for the eye. We can see things that were previously invisible, allowing us to detect subtle changes even before they affect vision.
So we're not just relying on those pressure readings in the eye exam anymore.
Exactly. Imaging gives us a much deeper understanding of the structural changes happening in the eye, and it helps us track the progression of the disease over time. It's an invaluable tool for both diagnosis and management.
Okay, walk me through some of these imaging techniques. The source material mentions pachymetry, stereodiscotography, and something called OCT. What are those all about?
Biochemistry measures corneal thickness, which, as we discussed earlier, can affect those IOP readings.
Sure.
Then there's stereo disc photography, which gives us detailed 3D images of the optic nerve head, allowing us to track changes over time.
So those are more like traditional photographs, just highly specialized for the eye.
Exactly. But the real rock star of glaucoma imaging is OCT, or optical coherence tomography.
OCT, okay, I've heard of that, but refresh my memory. What makes it so special?
Think of it as an ultrasound for your eye, but using light instead of sound waves. It gives us incredibly detailed cross-sectional images of the retina and optic nerve, allowing us to see the individual layers and measure their thickness with amazing precision.
So we can see the actual thinning of the retinal nerve fiber layer, which happens in glaucoma even before it's visible with a regular eye exam.
Precisely. And OCT technology is constantly evolving.
Wow.
There are different types of OCT scans that can give us even more information.
Okay.
The GCC scan, for example, focuses on the ganglion cell complex, which is another area affected early in glaucoma. It's like having a microscopic view inside the eye.
Incredible. And the source material mentions a couple of other imaging techniques: confocal scanning, laser ophthalmoscopy, and scanning laser polarimetry. What are those all about?
There are also powerful tools that provide unique information about the optic nerve and retinal nerve fiber layer. Confocal scanning laser ophthalmoscopy, or HRT, builds a 3D image of the optic nerve, highlighting its contours, and any areas of thinning scanning laser polarimetry, or GDX, assesses nerve fiber layer thickness by measuring how light is scattered as it passes through the retina.
So it's like having a whole team of specialists working together, each providing their own expertise on the case.
Yeah.
But imaging is just one part of the puzzle, right? The source material also talks about this visual field testing, or perimetry.
Right.
Why is that important in glaucoma?
Perimetry is crucial because it maps out your field of vision, showing us how well you can see in different areas. As glaucoma damages the optic nerve, specific areas of your vision start to disappear, creating blind spots called scotomas.
So those scotomas are like holes in your vision.
Exactly, and the location and pattern of those scotomas can provide valuable information about the stage and progression of the disease.
So walk me through this. What actually happens during a visual field test?
You sit in front of this dome-shaped machine and focus on a central target. Then lights flash at different points in your peripheral vision, and you press a button every time you see one. The machine records the sensitivity of your vision in each area, creating a map of your visual field.
So it's like playing a video game, but with your vision as the controller.
You could say that. And there are different types of perimetry.
Oh.
Static perimetry uses stationary lights, while kinetic perimetry uses moving lights to map out the boundaries of your vision. But the most common type used for glaucoma is standard automated perimetry, or SAP.
And what makes SAP special?
SAP uses a sophisticated algorithm to determine the faintest light you can see in each location, giving us a very precise measurement of your visual sensitivity. It's like testing the limits of your peripheral vision.
Okay, I'm starting to understand why those visual field tests can feel so intense, but how do they actually interpret those results? What are they looking for?
They analyze the results in several ways, looking for patterns of vision loss that are characteristic of glaucoma. They look at things like the reliability indices, which tell us how well you paid attention during the test. Then there are the sensitivity values, which show the actual measurements of your vision in different areas. They also look at probability plots, which show how likely a defect is to be significant, and summary values, which give us an overall picture of your visual field health.
So it's not just about whether you see the lights, but how bright they have to be for you to see them, and whether those thresholds are changing over time.
Exactly. By comparing your visual field tests over time, they can see if the damage is stable, getting worse, or hopefully getting better with treatment. They can also use the results to adjust your treatment plan if needed.
Speaking of treatment, let's dive into that next. The source material mentions a whole arsenal of options, from medications to laser treatments to surgery. What's the first line of defense when it comes to treating glaucoma?
The ultimate goal of glaucoma treatment is to lower that IOP and prevent further damage to the optic nerve.
Right.
And the first line of defense is usually medication, specifically eye drops.
Okay.
There's a whole pharmacy of different glaucoma drugs,
Yeah.
each working in a slightly different way to achieve this goal.
Okay, I'm ready for another crash course. Give me the rundown on these different glaucoma medications.
First up, we have the prostaglandin analogs, often the first choice, because they're very effective at lowering IOP and only need to be used once a day. They work by increasing the outflow of aqueous humor. Think of it like unclogging the drain in your eye.
That sounds promising, but I'm guessing there are side effects.
There are, as with any medication, prostaglandin analogs can cause darkening of the iris and eyelashes, which might be something to consider if you have light-colored eyes.
Interesting. What other options are there?
Next, we have beta blockers. These
Yep.
are another common class of drugs. They work by decreasing the production of aqueous humor.
Okay.
So instead of unclogging the drain, they're turning down the faucet.
Okay.
They're generally effective, but they do come with cautions, particularly for people with asthma or certain heart conditions, as they could affect heart rate and breathing.
So definitely something to discuss with your doctor. What about those alpha-2 agonists the source material mentions?
Alpha-2 agonists are unique because they work in two ways. They decrease aqueous humor production and increase its outflow.
Oh, wow.
So they're like a double whammy on that IOP.
Right.
But they could have side effects too, like dry mouth and fatigue. So it's all about finding the right balance for each individual.
Okay, we've got the prostaglandin analogs, the beta blockers, and the alpha-2 agonists. What else is in our glaucoma medication toolkit?
We also have topical carbonic anhydrase inhibitors, which work by blocking an enzyme involved in the production of aqueous humor. They're like enzyme blockers for the eye, specifically targeting that pressure-building fluid. They can be quite effective, but some people experience stinging or blurred vision as side effects.
It's like a game of pros and cons with each medication. And lastly, the source material mentions miotics. What's their role in glaucoma treatment?
Miotics are interesting because they constrict the pupil, which helps to open up the drainage angle. They're not used as often for open-angle glaucoma, though, because they can cause side effects like blurred vision and headaches.
So it's like the opposite of those dilating drops you get at the eye doctor.
Exactly. But in certain cases, they can be helpful, especially in managing angle closure glaucoma.
Wow, that's a lot to digest. So how do doctors decide which medication or combination of medications is right for a particular patient?
It's a very individualized process.
Okay.
They consider the type and severity of glaucoma, the patient's overall health, their lifestyle, and their tolerance to different medications. It's a balancing act, finding the best approach to lower IOP without causing unacceptable side effects.
And what if eye drops aren't enough? What happens then?
That's when we move on to other treatment options like laser therapy or surgery.
Okay.
But before we jump into those, let's take a step back and talk about a condition called ocular hypertension.
Ocular hypertension, that sounds ominous. What is that exactly, and how is it related to glaucoma?
Ocular hypertension, or OHT, is a tricky one. It means you have high IOP, but without any detectable damage to the optic nerve or visual field yet.
Okay.
Think of it like being in the danger zone, but not actually in the fire.
So it's like a pre-glaucoma state, but if there's no damage yet, why worry about it?
Because people with OHT are at a much higher risk of developing actual glaucoma down the road. The challenge is figuring out who's most likely to progress and when to intervene. It's a bit of a waiting game, but we do have some clues to help us make those decisions.
So how do they assess the risk of someone with OHT developing glaucoma?
They look at several factors, including the level of IOP, age, corneal thickness, there it is again,
Right.
family history of glaucoma, and even things like vascular health and history of migraines.
Wow.
And a landmark study called the Ocular Hypertension Treatment Study, or OHTS, provided valuable insights into this risk assessment.
Okay, tell me about this OHTS study. What did it reveal?
The OHTS followed a large group of people with OHT for several years. It found that treating OHT with medication could reduce the risk of developing glaucoma by about half, which was huge news.
That's amazing. So does that mean everyone with OHT should be treated?
Not necessarily. It's a decision that needs to be made on a case-by-case basis, weighing the potential benefits of treatment against the potential side effects of the medications. Some people with OHT have a low risk of progressing to glaucoma, and for them, the risks of treatment might outweigh the benefits. It's a complex decision that involves careful consideration and open communication between the doctor and patient.
That makes sense. So not everyone with high eye pressure will develop glaucoma, and not everyone with OHT needs treatment right away.
Right.
It's all about assessing the individual risk factors and making informed decisions. But let's circle back to those different types of glaucoma we talked about earlier.
Okay.
The source material dives deeper into each one, but can you give us a quick recap of the key distinctions between open angle and angle closure glaucoma?
Absolutely. It's crucial to understand the difference because the urgency and treatment approach can vary significantly in open-angle glaucoma. The drainage angle is open, but the fluid isn't draining efficiently, leading to a gradual increase in pressure.
Okay.
This type is often slow progressing and might not cause noticeable symptoms until significant damage has already occurred.
And that's why those regular eye exams are so crucial, especially as we get older.
Yes, exactly. Early detection is key in open-angle glaucoma because once vision is lost, it can't be recovered now in angle closure glaucoma. The drainage angle is completely blocked, causing a rapid and often painful spike in pressure.
So it's like a plumbing emergency.
You got it. And this type requires immediate attention to lower the pressure and prevent irreversible damage to the optic nerve. Understanding the distinction between these two types can literally be the difference between preserving your vision and facing potential blindness.
Wow, that puts things into perspective. It's amazing how much we've already learned about the workings of the eye and the complexities of glaucoma, but we've only scratched the surface. What comes next in our deep dive?
Next, we'll delve deeper into the specific types of glaucoma, exploring their unique characteristics, risk factors, treatment approaches. Get ready for a fascinating journey through the world of primary open-angle glaucoma, normal tension glaucoma, primary angle closure glaucoma, and the intriguing realm of secondary glaucomas.
Sounds like we're in for an eye-opening experience.
It will be. All right, so let's unpack these different types of glaucoma. First up, primary open-angle glaucoma, or POAG. Remember that slow leak in the faucet analogy? It's POAG. The drainage system isn't completely blocked, but it's not working efficiently, causing a gradual buildup of pressure.
And this is the most common type, right? The textbook mentioned it being particularly prevalent in certain ethnicities.
Yes, POAG is the most common type globally. It's especially common in people of African descent. And there seems to be a strong hereditary component. If you have a family history of POA, your risk goes up significantly.
So genetics play a role. I'm curious, are there any genetic tests available for glaucoma?
There are some genetic tests for specific types of glaucoma, but they're not routinely used for POA yet.
Okay.
The genetics of POA are complex, likely involving multiple genes and environmental factors. It's an active area of research, though, and we might see more widespread genetic testing in the future.
That makes sense. It seems like with most diseases, genetics are playing a bigger and bigger role in our understanding. But besides genetics and ethnicity, what other risk factors should people be aware of for POA?
Age is a big one. As we get older, our risk of developing POA increases. And interestingly, the textbook mentions a possible link between POA and vascular conditions like diabetes and high blood pressure.
Really? So it's not just about the eye itself, but also about the overall health of the circulatory system.
That's what the research suggests, though. The exact mechanisms are still being investigated. It highlights the interconnectedness of the body and the importance of maintaining good overall health.
It's like everything is connected. So let's say someone goes for an eye exam and they're diagnosed with POA. What happens next? What does the treatment look like?
The first step is often starting eye drops to lower the IOP. Remember those different classes of medications we talked about earlier?
Right.
The choice of medication depends on several factors, including the severity of the glaucoma, the patient's individual needs, and their tolerance to the different drugs.
So it's a personalized approach, finding the best fit for each patient.
Exactly. And if eye drops aren't enough to control the pressure, the next step might be laser trabeculoplasty, that laser procedure we discussed that helps improve the outflow of aqueous humor.
That tune-up for the drainage system, and if laser treatment isn't enough...
Then surgery might be an option. Trabeculectomy, where they create a new drainage channel in the eye, is the most common surgical procedure for POA. But the good news is that with early detection and proper management, most people with POA can preserve their vision and live normal lives.
That's reassuring to hear. Okay, so we've covered POA. The textbook also talks about normal tension glaucoma, or NTG. You mentioned this one earlier, and it sounds particularly tricky. Remind me what makes NTG so challenging.
NTG is a bit of a medical mystery because it causes damage to the optic nerve even when the IOP is within the normal range. Is like a silent thief stealing your vision without setting off any alarms.
So how do they even know it's glaucoma if the pressure is normal? What clues them in?
It's a process of elimination and careful observation. They have to rule out other possible causes of optic nerve damage, like a brain tumor or multiple sclerosis. And they look for characteristic patterns of damage in the optic nerve and visual field, often more localized and closer to the center of vision than in POAG.
So it's like a more subtle form of glaucoma requiring a more nuanced approach to diagnosis.
Exactly. And the cause of NTG is still not fully understood, which makes treatment even more challenging. There are theories about vascular dysregulation, meaning problems with blood flow to the optic nerve, as well as structural weaknesses in the optic nerve itself.
So it might not just be about the pressure, but also about the vulnerability of the optic nerve itself.
That's the thinking. Some people's optic nerves might be more susceptible to damage even from normal pressure levels, and there's even a theory that autoimmune factors might play a role. It's a complex puzzle that researchers are still piecing together.
It sounds like NTG requires a particularly vigilant approach from both the doctor and the patient.
Absolutely. It's all about close monitoring, careful assessment, and a tailored treatment plan that takes into account the individual's unique risk factors and progression.
Okay, let's move on to another type of glaucoma mentioned in the textbook, primary angle closure, or PAC. You describe this one as a plumbing emergency. What are the telltale signs that someone might have PAC?
Unlike the slow and silent progression of open-angle glaucoma, PAC often presents with more dramatic symptoms, though it can also be asymptomatic.
Right?
Classic symptoms include sudden blurry vision, eye pain halos around lights, headache, and even nausea.
So those are red flags that shouldn't be ignored what's happening in the eye to cause these symptoms.
Remember that drainage angle? In PAC, the angle becomes completely blocked, causing a rapid spike in pressure. It's often due to the iris, the colored part of the eye, pushing against the drainage system and preventing the aqueous humor from escaping.
So it's like the iris is slamming the door shut on the drainage system.
That's a great way to put it. And this pressure spike can damage the optic nerve very quickly, so it's crucial to get immediate treatment.
What does that treatment look like? How do they address this plumbing emergency?
Well, the first goal is to lower the pressure as quickly as possible, often with a combination of medications.
Okay.
They might use beta blockers to decrease aqueous humor production, alpha-2 agonists to increase outflow, and even oral medications to draw fluid out of the body and reduce the pressure in the eye.
So it's a multi-pronged attack on that pressure spike. What happens after the pressure is under control?
Once the pressure is stabilized, they'll often recommend laser iridotomy. This procedure creates a small hole in the iris, allowing the aqueous humor to bypass the blockage and flow freely.
There's a hole in the iris. That sounds intense. Is it safe?
It sounds dramatic, but it's actually a very safe and effective procedure. They use a highly focused laser to create a tiny, precise opening in the iris, and it's usually done right in the office. It's like creating a detour around that blocked road, allowing traffic to flow smoothly again.
That's a great analogy. So they tackle the immediate crisis with medications and then aim for a long-term solution with laser treatment. But what if those treatments aren't enough?
In some cases, particularly if there's significant damage or the angle remains narrow, despite laser treatment, surgery might be necessary. Trabeculectomy or the implantation of a glaucoma drainage device can provide alternative pathways for the aqueous humor to escape, preventing further pressure buildup and protecting the optic nerve.
So just like with open-angle glaucoma, there's a whole range of options, from less invasive to more surgical, depending on the individual situation.
Exactly. And with prompt diagnosis and treatment, most people with PAGA can avoid serious vision loss. But early detection is key. Which brings us back to the importance of those regular eye exams, especially for people with risk factors like a family history of glaucoma, farsightedness, or being of Asian descent, as these groups have a higher incidence of TOC.
Okay, we've covered the big three, POAG, NTG, and POC now. Let's talk about the last category mentioned in the textbook, secondary glaucoma. What makes these glaucomas different?
Secondary glaucomas are a diverse group of conditions where something else is driving the IOP elevation. It's like the glaucoma is a symptom of another underlying problem.
So it's not a primary issue with the eye's drainage system itself, but rather a consequence of something else going on.
Exactly, and the causes are incredibly varied, ranging from eye injuries and inflammation to tumors, certain medications, and even cataracts.
Wow, that's a wide range of possibilities.
Yeah.
The textbook mentions a lot of specific types of secondary glaucoma, but can you give us a few examples that really highlight this diversity of causes?
Absolutely. Let's start with pseudo-exfoliation glaucoma, or PSG. This one is fascinating because it's caused by the buildup of a flaky material in the eye, particularly on the lens and in the drainage angle.
It's like the eye is getting dandruff.
That's a pretty accurate description. This material, called pseudo-exfoliation material, can clog up the drainage system, leading to glaucoma that often progresses more rapidly than primary open-angle glaucoma.
So it's a mechanical obstruction, like debris blocking a pipe. What about pigmentary glaucoma? That's another one that sounds interesting.
Pigmentary glaucoma is caused by the release of pigment granules from the iris, the colored part of the eye. These granules can accumulate in the drainage angle and obstruct the flow of aqueous humor.
So it's like the eye is shedding its color and those tiny bits of pigment are clogging the drain.
Exactly, and it typically affects people who are nearsighted and those who engage in vigorous physical activity, as the movement can cause more pigment to be released.
That's fascinating. And the textbook mentions a particularly serious type of secondary glaucoma called neovascular glaucoma. What's the story with that one?
Neovascular glaucoma is a sight-threatening condition often associated with other eye diseases like diabetic retinopathy or retinal vein occlusion. It's caused by the growth of abnormal blood vessels in the eye, particularly in the iris and the drainage angle.
So it's like the eye is trying to compensate for poor blood flow by growing new vessels, but those vessels end up causing more harm than good.
That's a good way to think about it. These abnormal vessels are fragile and leaky, and they can block the normal drainage of aqueous humor, leading to a rapid and often severe increase in pressure.
It sounds like a very aggressive form of glaucoma requiring urgent treatment.
It is, and treatment often involves addressing the underlying cause of the abnormal blood vessel growth, such as controlling diabetes or treating the retinal vein occlusion.
Okay.
They might also use medications to inhibit the growth of those new vessels and laser procedures or surgery to improve drainage and lower the pressure.
So it's a multifaceted approach tackling the root cause and the glaucoma itself.
Exactly. And the earlier it's detected and treated, the better the chances of preserving vision.
That's a powerful message for all types of glaucoma, but especially for these secondary glaucomas where early intervention can make such a difference.
Absolutely. Recognizing the symptoms and seeking prompt medical attention could be crucial in preventing irreversible vision loss.
Well, we've covered a lot of ground in the world of adult glaucoma, from the basic science to the different types, causes, and treatment options, from medications to laser procedures to surgery. It's amazing how much we've learned about the eye and the complexities of this potentially blinding condition.
It's a testament to the incredible advances in our understanding of the eye and the development of innovative treatments that can preserve vision for many people with glaucoma.
Absolutely. But before we wrap up, I'm curious, is there anything specific from all this information that really stands out to you? What are your key takeaways?
What strikes me most is how diverse glaucoma really is. It's not just one disease, but a spectrum of conditions with different causes, risk factors, and treatment approaches. Understanding this diversity is crucial for both doctors and patients because it highlights the importance of personalized care and the need for ongoing research to develop even more effective treatments.
That's a great point, and it also underscores the importance of regular eye exams for everyone, regardless of age or risk factors. Early detection is key to preserving vision.
Absolutely, and don't hesitate to ask your eye doctor any questions you might have about glaucoma or any other eye condition. The more you know, the better equipped you'll be to protect your precious vision.
Well said. I think our listener is well on their way to becoming a glaucoma expert after this deep dive, but I'm curious, is there anything else you'd recommend they explore further based on what we've discussed today?
One area I find particularly fascinating is the ongoing research into the genetics of glaucoma. We talked about the role of genetics in POAG, but there's so much more to discover.
It's like a genetic treasure hunt for clues to glaucoma. What could this research lead to?
Imagine a future where we can identify people at high risk of developing glaucoma even before they show any signs of the disease.
Wow.
That would allow for even earlier intervention and prevention, potentially stopping glaucoma in its tracks before it causes any damage.
That would be a game changer. It's amazing to think about the possibilities.
Absolutely. And it highlights the importance of supporting ongoing research and staying informed about the latest advances in glaucoma care.
Well, I think we've given our listener a fantastic foundation to build on. They're now armed with the knowledge and awareness to take charge of their eye health and advocate for themselves if they have any concerns.
And hopefully, with a newfound appreciation for the incredible complexity and resilience of the human eye.
You know, it's incredible to think about how much our understanding of glaucoma has evolved even in recent years.
It really is. We've come a long way from just, measuring eye pressure to having these sophisticated imaging techniques that can detect subtle changes in the optic nerve and the retina long before any vision loss even occurs.
Yeah, it's like we're getting a sneak peek into the future of the disease.
Exactly. And that early detection is key to preventing irreversible damage. What's also fascinating to me is the realization that glaucoma isn't just one disease, but a whole spectrum of conditions, each with its own unique characteristics, risk factors and treatment approaches.
Right, like almost every disease, it seems, these days.
Exactly.
It's like a giant puzzle with each piece representing a different aspect of the disease.
Yeah, and we're still putting the pieces together. There's so much we don't know yet about the underlying mechanisms of glaucoma and why some people are more susceptible than others.
Right, which makes it all the more important to stay informed and proactive about our eye health.
Absolutely. And to advocate for yourself, if you have any concerns, don't be afraid to ask your eye doctor questions and get a second opinion if needed. Knowledge is power, especially when it comes to protecting your vision.
Well said. I think our listener is well on their way to becoming a glaucoma expert after this deep dive.
Yeah.
But I'm curious, is there anything else you'd recommend they explore further based on what we've discussed today?
Well, what I find particularly intriguing is the connection between glaucoma and other health conditions. We touched on the possible link between POAG and vascular diseases like diabetes and high blood pressure, but there's a whole world of research exploring these connections further.
So it's not just about the eye itself, but about the overall health of the body.
Exactly.
Yeah.
For example, some studies suggest that sleep apnea, a condition where breathing repeatedly stops and starts during sleep, might also increase the risk of glaucoma.
Wow, I never would have thought about a connection between sleep and eye health.
Yeah, it's fascinating, isn't it? And it highlights the importance of taking a holistic approach to healthcare. What we do to take care of our bodies as a whole can impact our eye health and vice versa.
That's a powerful message. It's like everything is connected and we need to treat our bodies with that understanding in mind.
Precisely. And as we learn more about these connections, we might uncover new ways to prevent and treat glaucoma that go beyond just focusing on the eye itself.
It's an exciting time to be in the field of glaucoma research, that's for sure. But for now, we've armed our listener with a wealth of knowledge about this complex and potentially blinding condition. They're ready to face the world with eyes wide open, both figuratively and literally.
And hopefully with a newfound appreciation for the intricate workings of their vision and the importance of protecting it.
Thanks for joining us on this deep dive into the world of glaucoma. Until next time, keep those eyes healthy and those minds curious.